on the way. The last one that did make it to Delhi, the treatment was so expensive. They had to sell their house, they had to sell their fields, and then he died anyways later. And now look, his widow is begging on the streets. It is still a fireable offense in our organization if you turn back a patient due to financial reasons, saying this patient did not have money, so we will not treat them.
Let me make sure I heard that correctly. If somebody, one of your staff, refuses a patient
Yeah.
because of financial reasons, you fire them.
No questions asked.
Hello, and welcome to another episode of the Steward Leadership Podcast, where we speak to steward leaders who are profitably solving an environmental or social issue. Today, we are in Kashmir, India, which is also known as Heaven on Earth. Today, we have with us Dr. Shuchin Bajaj, founder and director of Ujala Cygnus Hospitals. And I'm going to be talking to him about what he does, and how, as a steward leader, he is solving the problem of last mile healthcare in remote areas of India. Welcome, Shuchin, to the show.
Thank you very much, Rajiv, and welcome to Kashmir. Welcome to our Srinagar hospital, which is the pride of our chain. Really, really happy to host you here and really happy to speak to you.
Pleasure's all mine. So, in an interview recently, you said that you were pursuing your studies and you stopped halfway to start this business. Tell me a little bit more about what you were trying to do and how come you ended up founding Cygnus Hospitals, and what is the mission that you're after?
See, I come from a resource-constrained family, to put it mildly. My parents were refugees into the country after the partition and independence. And my father, in his initial days, used to live in a horse stable the size of, say, 10 feet by 8 feet kind of a place with 15 other people making kites for a living. And he decided very early on that education was the way out of poverty. And he literally climbed out of poverty by climbing to the roof of the horse stable to make a study room for himself, because he could not study in the stable because there were 15 other people who would beat him up if he lighted a lamp to study at night, because they were thinking that if the kites catch fire, we won't have anything to eat tomorrow. So he took a rope and climbed onto the roof of the horse stable, stayed there for a long time, studied there, and really, really got well educated, did his PhD. And
He came in as a refugee, if I recall, from what was then Pakistan.
Yeah. He used to live in a very small town called near Sargodha, in a village. And when he came to Delhi, he was, they were allotted various places to stay. So our family got a horse stable allotment outside a Haveli. And he used to live on the roof there. He built a shack out of tarpaulin and other stuff that he gathered from the railway station, which was close by. And this was his favorite dialogue that he always used to tell us: if you want a roof on your head instead of under your feet, like I had, then you have to study. So we really studied at the peril of death, because he was a very strict father, like the fathers of old.
So you became a doctor.
Yeah, so I became a doctor. Luckily, I got through this exam, which is one of the toughest exams, right? I mean, in our times, we only had about 2,000 seats in that central exam and more than 10 lakh people appearing for it or whatever. I mean, it was a very, very tough exam. Luckily, I was very lucky that I got through. And my annual fees, I remember, was 413 rupees at that time for the whole year of medical school, which is like $5 or something. And did my MBBS, then finished my MD in internal medicine. Came back to Delhi after roaming around Haryana, Bombay, and Rajasthan for my studies. And in Delhi, I was working in gastroenterology, which is considered to be a super specialty, as we call it. We're like conceited doctors, right? So I was doing gastro, but since I was back in Delhi and most of my family and friends lived in and around Delhi, I would get a lot of calls that somebody's had a heart attack, somebody's had a head injury, can you help us in some way? The patient is critical, we are bringing them to Delhi. On the one hand, of course, it felt very nice that now I was in a position, I was a doctor in the family, I could help these people. And some of them are still struggling to come out of poverty, right? But on the other, it always kept knowing me from inside that why were these people traveling 5-6 hours in a hired jeep with a critical patient? Cell phones were not very common at that time, and sometimes they wouldn't turn up. I would keep waiting for them all night, and I would get to speak them the next morning, and then they would say, oh, patient died on the way, so we are back in the village now, we couldn't come to Delhi.
So that's how the idea came to your head that we need to take this kind of critical care to them.
Yeah, I mean, the idea first was how to get them quickly to Delhi, right? Because they were dying on the way. So I thought, I'm working in Delhi, how can I get them quickly? But because I knew them very well and I would go to their funerals, so kind of design thinking happened at that time. I had no idea of the word design thinking, of course, at that time. But I sat with them and I realized that bringing them to Delhi was not solving the entire problem, because I would hear stories like, oh, maybe it's good that this one died on the way. The last one that did make it to Delhi, the treatment was so expensive. They had to sell their house, they had to sell their fields, and then he died anyways later. And now look, his widow is begging on the streets. So maybe it's good, that they didn't go to Delhi, so they didn't have to sell their house. So then I realized that bringing them to Delhi was not really the solution, right? They had to have hospitals or good quality healthcare nearer their houses. And we call them small towns, but nothing is really small in India, right? Each of these towns is like 10 lakh, 20 lakh people. India has more than 800 districts with 150 crore people, right? So 2 crore, 20 million people on an average to a district, and some districts are much more populated. So this is where I felt that healthcare needed to be brought closer to these people and at much, much cheaper prices than was currently
Okay.
available.
All right. So that's the
So
genesis.
that's how the
And how do you
thought
describe the
process came.
mission now of what you're up to?
So I think
If
my
you were to
life
succinctly
now,
say it in one sentence,
yeah,
what are you trying to do?
my life is now fully dedicated to dissociating access to high quality healthcare from your financial, social, or geographical status. It should not
Financial,
matter.
social, and geographical.
Geographical. It should not matter where you live. It should not matter what caste you were born in or which family you were born in. And it should not matter how much money you have in your pocket. These things should not affect your quality of life or length of life. And you should not be dying because, you're living in a small town where you have a heart attack and there's no, critical care
It
available.
sounds amazing, but it's definitely not easy. The challenges you're dealing with are enormous. Not only are you saying that, people who can't pay, we'll still treat them. We will take healthcare to your doorstep, no matter how remote the area you live in. This is not easy stuff. What makes you persist? And I'm sure since you started the journey, 15 years ago, you've had your share of ups and downs, and I'm assuming more downs than ups. What makes you persist? How do you keep going? And then after this, I want to get quickly into your business model and your story. But just a little bit more. You've been at it for some time and haven't given up.
Yeah, it's been a long, long time. And, you know, uh, people always, in my earlier days, especially, people used to always tell me there's a Hindi phrase called ulti Ganga bahana, right? So you're trying to go the opposite direction to everyone.
So
So
which translates to sort of flowing the Ganges in the
yeah,
opposite
yeah,
direction.
correct. Yeah, yeah, absolutely in the wrong direction. Because I used to hear this, that people grow up in small towns, they come to big cities, and then from the big cities they go to countries like US, UK. You're already in Delhi, trying to become a super specialist, and now you're trying to go the opposite way. This is really a stupid thing to do, and I heard that a lot of times.
I believe your own family was upset with you when you said
My father was so angry at me, because as I told you, he was, in his heart, everything was about education, right? That you have to get educated to do anything in life. And the fact that I dropped out of education to start this made him so angry. He refused to speak to me for a very long time.
And then how did you keep persisting
So
despite all the challenges?
the day he started talking to me again was the day when one of his cousins, who lived in a town called Panipat, had a major heart attack at 1 a.m. in the night. So his son took him to a hospital there. And at that time they said that this is a very serious patient, he has a heart attack, you have to take him to Delhi, there's no other way. So he started towards Delhi, and then suddenly he remembered that they call me Kaku at home. That's my nickname. So he said, Kaku has a hospital in Panipat. He told me somehow, right? So he called me at 2 a.m. and said, hadn't you opened a hospital? I said, yeah, of course. So he said, okay, where is it? Tell me the address. So he turned back, came into our hospital in say 10, 15 minutes. At that time, his father was clinically dead. I mean, we had a straight line. So in the emergency, they cardioverted him with those DC shocks, and took him to the cath lab immediately, put in a stent, and he survived. And he told my father later that, I'm surviving because I could never have made it to Delhi. It was like a 3 hour, 2.5 hour drive. So then my father said, maybe you're doing something right. but he did not visit any of our hospitals till the day he was alive. So he was not very, very happy, but he was like, okay, let's see what you do.
So coming
But
back, what keeps you going?
all these stories,
All
right?
these
These
stories, yeah.
this
Perfect.
So every time I'm in trouble, and I've been in trouble a lot of times, the company, I mean, it's not really, as you said, it's to put it very mildly, it's not easy to do this in small towns. And we have a lot of issues getting good quality doctors, good quality staff, managing the cash flows, because the community wants to pay less but the medical staff wants more, because they are look at it as a punishment posting, right? They're staying in small towns. So it's a very kind of a tightrope walk. But every time I'm in trouble, I go back to, why did I start this? What was the reason?
The
Why did I
purpose.
not become a gastroenterologist? I could have been a very rich gastroenterologist. But every time I am in doubt, I go back to the same reason. Why did I start this? And then I realize that there's so much more to be done, right? I
Yeah,
mean,
keeps that purpose keeps you going. Yeah,
yeah.
perfect. All right, wonderful. So again, summarize for me as quickly as you can. What's the business model? How do you make money providing affordable or even free healthcare in tier two, tier three cities and villages, even to people who cannot pay? What's the magic? How do you make money?
See, Rajiv, traditionally, private healthcare has been all about high costs and low volumes, because people can't afford. So, a very few percentage of the people goes to these, big hospitals. We are trying to flip this model into a low cost, high volume business. That is all we are trying to do. It's a classical cross subsidy model. We try and get in as many patients as we can, and we try and keep the costs fixed. Right. So once your costs are fixed, if you're not doing a fee for service sharing model, your rentals try to be fixed, your doctor costs try to be fixed, salaries fixed, logistics, etc., electricity, all of them are practically fixed. Once you keep all your costs fixed and efficient, once you cross a certain Rubicon of revenue, then more than 50% of it will start flowing into the bottom line. So the secret is to be really efficient. Make sure you treat patients well the first time. You do not have complications. You do not readmit them. You do not, have stitches which are going bad. So keep them in for a small, short while and treat them well. And then you can afford to, treat them at really, really
And
low
it's working.
prices. Yeah, I mean, it's been now more than 15, 16 years, and we are still surviving and still opening more hospitals. So we started with very one small one. Now we have 23 hospitals across 5 states. We make a decent EBITDA margin, almost 13 to 14% EBITDA margin. And our aim is to go up to 17, 18%. We closed last year's revenues at almost 600 crores. Next year, hopefully, we'll do more than 1,000 crore revenue. So, yeah, I would say
So
it's
coming
pretty
back to
much,
your EBITDA positive, right?
yeah.
Now, Charlie Munger, who was Warren Buffett's partner all his life, he used to say EBITDA valuation is quote unquote BS valuation.
Yeah.
So investors, some investors anyway, and I know you've got good investors, but some investors will be skeptical about the long-term longevity and the sustainability of your finances. And also some patients might be angry because if you're in by tier three cities, you're always struggling to get the best doctors, etc. What do you have to say for all these skeptics?
So I'll answer the second part, because for me, patients are most important. So I would take their concerns very seriously. Investors, of course, are very important, but we can, put them second. So getting the best doctors, I think we'll just walk around the hospital after this, and you'll see the doctors that we have working here. They've come from out of Kashmir, definitely, but from out of India as well, out of the country as well. And they're all happy working here with us because they understand that the purpose of this organization is not really, about Excel sheets or earning money. It's more about treating patients really very well. And doctors love that. They love working hard for patients, for their patients, At the same time, of course, earning money is important, but that should not be the first purpose. So we get a lot of good doctors working with
So you
us.
get a
Once,
certain kind of doctor then, because there's a lot of doctors who are only money minded.
so you must ensure that you avoid these mercenaries a lot. See, in
Right.
every field, there will be 10% of the people who will be pure mercenaries,
That's
that
right.
I am here just for the money. Then there will be 10% people who will be pure missionaries, that I am here just for the purpose. If you can find anyone like that, just hold on to him or her and do not let them leave whatever happens. But they're difficult to find, right? Majority people are people who would work if you give them a structure, but they're too afraid, I think, to make it on their own. I mean, they would say, okay, if you have a structure, I'm happy to work on it. I'll give you a very small example and a quick example. During COVID times, I was part of this beautiful organization. I'm still a trustee there, called Project Step One. We started it as a small WhatsApp group called Founders versus COVID, because we knew that something huge was coming and the government and everybody else was not really prepared for it. So we thought we should do something. In that, we started a helpline, a small helpline where doctors could come in, and we, because there were founders who were not doctors, I think, the only doctor in that group. Most were techie founders, so they were very good at making softwares and everything work. So we made a small software where a doctor could just switch on his availability on the phone, say I am available to do a teleconsult. They would get 5 teleconsults lined up, and then they could switch it off, saying I don't want to do more than 5. So every time they would indicate their availability 5, so they could do 20, they could do 100, whatever worked. And then they could make a call like you call an Uber cab, where the numbers on both sides are masked, so the patient doesn't get your number, you don't get the patient's number. It's a central kind of a number. We made a helpline like that. Can you imagine? We made 98 million telecalls. We had 11,000 doctors volunteering on that platform, completely free. Nobody earned anything. Nobody got a name also. There was no name, no fame, no money. 11,000 doctors came on board, volunteered their time, and most of the time they were listening to patients' anger and rant that, I don't have medicines, I don't have food, and they were trying to calm them down. Doctors who we all consider to be, most egoistic people, they worked there because they got a structure to work, which they could work comfortably. So doctors really want to work well and hard for the patient. They just need a structure, and they need to be sure that nobody else is earning because of their work. So if they feel that you are earning, I should also earn more
Fair
than you.
enough.
But if you're not earning, I'm happy to
So
do
there's a
that.
lot of goodness in the world. You
Yeah.
provide them the platform and they will come. So that's not the
Absolutely.
issue. Coming
Absolutely, I
back to the
agree with that.
investors, though, those who are looking for the financial viability beyond EBITDA margins, what's your road to full profitability?
So, see, if you see the need of the patients, it's a huge need, right?
Huge need.
Huge unmet
It's
need.
underserved need.
Underserved need. But we also need to understand that in India, healthcare is not just undersupplied, it is under accessed as well.
Correct.
Our hospitalization rates are amongst the lowest in the world. Lancet Commission for Surgery says that a country, LMIC country like India should have about 5,000 surgeries per 100,000 population per annum. And this number can go as high as 23,000 in countries where awareness is very high and out-of-pocket expense is very low, like the Scandinavian countries. In Brazil, this number is 13,000. How many surgeries were conducted in India last year? Only about 2.5 crore surgeries. So our number is only about 1,600. Rest 3,500 are not getting the surgeries done at all. So we go village to village every day. We have this huge program called the Sehat Chopal, where we go to villages and talk to the people and create awareness, improve their health seeking behavior. We see these kinds of patients every day. There would be this old woman lying on a cot, and they will bring the cot to us to consult. They say she can't see, she is too old, she can't walk, and they consider it normal, right? It's old age. I mean, we need to tell them that she can see. If you do a cataract surgery, in 10 minutes, she'll start seeing. If you change her knee joint, she will start walking. This big lump that she has, if we remove it, she'll have a healthier life. This is the reason why most Guinness Book of World Records come out of India. No, you have these
The
happy
numbers are
doctors.
just enormous.
Yeah, happy doctors standing with a 15-kilo tumor saying, "Oh, we removed this tumor from this girl." This tumor should have been removed 10 years ago,
Yes,
when
right,
it
yeah.
was like a 200-gram tumor, but there's no awareness.
Right.
So
So you're
The
after the
need is
volume.
there, the volume is there, and with government insurance penetration increasing, with this Ayushman Bharat scheme that we have, with private insurance also now increasing, awareness and access is only going to rise. And this unmet need that is there, we will solve for that. I mean, everybody cannot come to Delhi or Chandigarh or Bombay to get their treatment. That is why these people are not coming. They can't afford it. It's not accessible to them. They have no awareness. The A's of healthcare that we speak about, right, at every A, people fall off the radar. So we are trying to solve for all of them. Each A we will solve for, and we will get the people in. And with the rising volumes, you will see the profitability and the sustainability of the business only rises
So if I
further.
summarize correctly, you're after volumes, and that will take care of the profitability issue because there's plenty of unmet need. B, you tap into the government schemes for those who cannot pay. Talk to me a little bit
Absolutely.
more about that one. You mentioned Ayushman Bharat, and then there are some other government schemes. Now, clearly, claiming that money from a government infrastructure in India is not easy. And I think you mentioned to me, or I heard you speak somewhere saying you've got a few billions waiting to be claimed from these schemes. So, what does that do for your cash flow, and how do you sort of circumvent that challenge?
Yeah. So, see, as I said earlier, our ethos is that healthcare access should not depend upon your financial, social, or geographical status. So, we are committed to treat each and every patient that walks into the hospital. It is still a fireable offense in our organization if you turn back a patient due to financial reasons, saying this patient did not have money, so we will not treat them.
Let me make
We
sure I heard that correctly. If
Yes.
somebody, one of your staff, refuses a patient
Yeah.
because of financial
Yeah.
reasons, you fire them.
No questions asked. Yeah. We have to treat
And
each.
have you fired a few?
Yeah, yeah, absolutely.
Okay.
As I said earlier, every time we have a doubt, we go back to the reason why
The
the
purpose.
organization was started, right? The reason was not to earn money. I could have earned a lot more money if I had become a gastroenterologist. The
Got it.
reason was to solve this problem of people dying on the road due to lack of access. So, any emergency that comes in, we have to treat that emergency. There is no question asked. We
And then
can't
how?
send out a patient with a heart attack saying, no, no, you have no money, you go to the government hospital, and the patient dies on the way. That is inexcusable.
That's wonderful. So coming back to the issue of cash flow,
Yeah. So,
you've got plenty of areas to collect
yeah.
from the
So,
government. How
so
do you?
as I said, the purpose stays strong. Before these government schemes were in place, when I started out, there was no such government scheme. So people actually had no one to pay for them. So we had to devise a lot of innovative solutions of arranging loans for these patients on EMIs of 2 years interest free, or talking to social organizations to get the money in, getting donations or whatever it was happening. But now the government pays for them, so at least somebody is paying for them. So that is a good thing for us. With increasing insurance penetration, as I said, it will become more and more, widespread. And hospitals that work on, there is a metric that we track called RPOB. That is the average revenue per operational bed per day. There are more than 17, I think now, listed hospital companies in India, and their financials are publicly available, so anybody can go and see them. The highest RPOB amongst those hospitals is more than a lakh rupees every day. Average around 50, 55,000, I think, of if you take all the 17. The government scheme's RPOB is less than 10,000. So less than 10% of what these big city hospitals are charging. Imagine now everybody in India gets this government insurance scheme. Then what do these big city hospitals do? In Kashmir, each and every citizen has this government scheme in place. You can get access to it regardless of whether you own a Mercedes or you own a cycle rickshaw. Each and every person has an Ayushman card. I agree that getting money out is a problem because government bureaucracy has always worked, in a certain way. It's a big ship, so it moves slowly. But with increasing technology in place, I believe that it will only get better. It is getting better over the last few years. There's a lot of faceless technology. Government is always afraid of frauds being committed, right? So they try and screen each and every case very thoroughly. But with now technology in place, You need to put a geo-tagged photograph of the patient along with the doctor. You need a pre-operative photograph on the OT table. You need a post-operative photograph. You need a photograph of the stent. You need an X-ray. Everything is there to make sure there are no frauds happening. And once the government, I think, has this full technology stack at play, there's a healthcare exchange coming up, HCX, where all claims will be visible to all payers in real time. So I think once that comes in, that technology will solve a lot for this time that is taken to screen, and the claims will get faster. I strongly believe in that. But I agree with you, it is tough for us right now to manage those cash flows. But see, even with these delayed cash flows, even with low payments which are as low as 10% of the what the normal hospitals are charging, even then, if we are profitable, that speaks volumes about what this model is and where it can go to.
And that's what your level of confidence is, that if we are this far, we'll get where we need to be soon.
Absolutely. We are opening 4 more hospitals this year. So we are very confident that this model works and is sustainable in the long run.
Besides the cash flow issue, what are one or two of your biggest challenges going forward?
As you correctly pointed out, getting good quality doctors to work in the small towns is a challenge that we always face. But again, as I said, it's getting much easier now
What's your
because of
strategy to attract and retain those doctors, especially the super specialty doctors that you talked about? Why should they come to a small town? And I want to get to Srinagar in a bit because we're running out of time. But what's your strategy in attracting and retaining in all your hospitals, for that matter?
Yeah. So, see, in a big city hospital, if you see, you usually have 3 levels of doctors. The top level is the biggest superstar doctor whose name is all across the world, who will go and treat the prime minister, also the chief minister of that state, also. The second level is actually the people that are working on a day-to-day basis. They're the real clinical people, because the superstar is busy in a lot of other things. So they are the people who are operating on a daily basis. They don't have that much name, but they are doing very good clinical work, and people from around the world are coming to them. So they're very happy. Then there's this third level who's now studied in the top medical schools of the country, has worked there also for 2 3 years post that, and now has come out of the government system to try his luck in the private sector and make a name for himself. But unfortunately, what is happening right now at the third level is that she or he is reduced to a glorified telephone operator, because she's not getting to cut, because the second level is doing all the cutting. Patients don't want to meet her because they're saying, no, I came for the superstar doctor, where is she? We want to meet her, because that is what we have come for from all the way across. So what she is doing right now is making these telephone calls. Patients BP is this is this, when she's going to the patient is saying, oh, my tea is cold, that is all I want to speak to you about. And she's come from a small town. So what we go and offer her is that earlier you had no where to ply your trade in that town. Now we've set up this wonderful hospital where you will be the head of the department. Come and set up your own clinical protocols. And since there is no financial pressure, because you are mostly on a fixed salary, the fixed salary allows us these 3 things very clearly, right? One, there is no financial pressure on the doctor to do unethical stuff, because there is no fee for service. So if a patient is coming in the middle of the night with chest pain, if the ECG is normal, the doctor is not saying let's do an angioplasty anyways, right? It is also encouraging good quality behavior, because at 3 a.m. she is not worried whether the patient is going to pay or not. She will come and do the angioplasty if required. And third, as I said, if we build enough volumes, most of it starts flowing into the bottom line, because we have no one to share it with. So we give them this beautiful place to work. We give them the entire department, clinical protocols. And once they come in, they quickly become the superstar of the town, because they're the first ones
That's
there.
right. So you're giving
People
them
are lining
opportunity
up.
to thrive. And
Yeah. So,
okay.
so this was very difficult to explain early on, because it was not live.
But now
Now
you
it is
have.
live in 23 occasions,
Yeah.
locations. So we just tell them, come and see the hospital and go and see some of
Yeah.
our other hospitals. Once you see it, they believe it, and then there's no stopping it. Once doctors join us, I mean, it is very difficult to let go.
That's for sure.
So you will meet
So,
Dr. Parvez today. He's been with us for more than 12, 13 years. So, once doctors join us,
clearly, you're trying to attract a certain kind of doctor, a certain kind of nurse, not just anybody. And clearly, you want to avoid those mercenaries you talked about earlier. So, how do you screen for that kind of values and purpose that you don't end up getting the wrong people?
I think the only way to do that is spend a lot of time with the prospective candidate and talk to them a lot. So making type 2 errors is something that we really avoid. We can afford to lose a few good doctors, but we should not hire the wrong doctor for sure, because then the whole purpose gets dissolved and the whole mission gets affected. It's very difficult to find the missionaries as well. Mercenaries is 10%, but missionaries are
Missionaries
only
also
also
very, yeah.
10%. Most of the doctors that we want to attract should be really motivated by the quality of work that they are going to get here, the ability to work independently, not be working under somebody else, and making good quality clinical outcomes for the patients. If they are attracted by that, slowly they'll get into the purpose of the mission of the community and solving for the community. We don't want to talk to them. I mean, most doctors would say, no, no, that is your work. We are here to do good quality clinical work. Can we get it done? If that is their question, they are the right candidates for us.
And then seeing you walk the talk every
Yeah.
day, and the other colleagues walk the talk, they become that. That's
Takes
great.
some time, but yeah, most of them do get there.
Okay, we are in Kashmir. Now you've got 23 hospitals, you said, all over, and you're trying to solve the last mile problem. Why Kashmir? Because this area has had a fair share of militancy, and some people call it a dangerous place for the last 3, 4 decades. And you came here several years ago when it was still pretty unsafe. What made you come here, and why Kashmir? Why Srinagar?
See, as I said, our communities that we're trying to address is not only the patients, it is the doctors as well, right? We want to work with good quality doctors, and Kashmir has some of the brightest brains in the world. I mean, most Kashmiris, if you see them outside the country, would be heading their institutions. They're very bright people. Unfortunately, we had no place for them to excel in their own towns, in
In
their
their own
own
state.
communities, in their own patients, and they would have to come outside because of this unstable political scenario of the location. So this is, I think, one of the best places to work in, because the quality of doctors is amazing, but also it has a lot of mental health and physical health issues because of the political scenario. And earlier, emergencies was a main concern there, which is our forte. Because of the political scenario, emergencies were not really working very well in this town, and Srinagar attracts the entire population of Kashmir to it. Right, it's the capital of the state. So I think this is the right place to be in. And fortunately, we've done very well here. We are already out of capacity. You see the hospital. You've seen the hospital. I mean, the patients are bursting at the seams. So we have no place for the patients. We are have to build another hospital here, the cancer center that we are trying to build and inaugurate. And the population is really, really aware also. As I said, the education levels and the IQ levels are very higher. So they're very aware. They want to access good quality healthcare, and this is what we are trying to offer them.
So not only are you a good Samaritan, you're also a very courageous one to come to a place like this where it's most needed. Well done. Okay, so last question. At what point do you think your work will be done?
I don't think it's going to be done in my lifetime. I think if it were to be done for me, it would mean that the second line of management that we are trying to build now, I think if they are able to work completely independently and I disappear from view completely and still the organization thrives and grows, I think my work would be done. But on a larger canvas, my work would be done if I can inspire more people to address these issues, not just in India, but all over the South. I think Africa needs these solutions, all of Asia needs these solutions. India itself has more than 800 districts, as I said, and even today, more than 500 of those districts have no access to good quality emergency tertiary healthcare. If you have a heart attack in any of those 500 districts, you will be forced to travel anywhere from 1 hour to 5 hours, 6 hours, depending on where you are, to access healthcare. So the golden hour concept is completely out of the window in those districts. So clearly, I can't do 500 hospitals in my lifetime. I don't think I can. Clearly, I can't go to each and every country that needs this. So my purpose would be done if people think it is a solvable issue, which I'm trying to show them, and get inspired to work in these difficult circumstances instead of just going to the big city like all most doctors want to do and settle in a large corporate hospital. If I can inspire a few of them to move out and go to small towns, my work would be done.
Brilliant. Wonderful. So there you have it, friends. Another example of doing well by doing good. Here is someone who is trying to solve a huge social challenge and do so profitably, doing well by doing good. Steward leadership, as you know, it's all about creating a collective better future, a genuine desire and persistence to create a collective better future. And steward leaders don't get afraid of challenges. And hopefully that's what came out in this conversation. Shuchin, it's been an absolute pleasure talking to you, and wish you all the very best in the journey ahead. And may you inspire many more Dr. Shuchin Bajajes all over the world. Thank you very much.
Thank you very much, Rajiv. Thank you.